Thank you for that introduction, and I'm delighted to be here today to talk to you a bit about ketamine and major depressive disorder, and specifically as it pertains to emotional processing. So to give you just a brief outline, I'm going to introduce the ketamine MOA study, which is the study that this manuscript was part of. And I'll talk a bit about the clinical results from that study, and then the emotional evaluation task, which is what was used primarily in this paper. And there are some behavioral findings from that task, as well as the MEG findings. So ketamine MOA was the ketamine mechanism of action study that was carried out at the NIH between 2011 and 2016. And the purpose of the study was to comprehensively characterize the response to ketamine in both major depressive disorder and healthy volunteers. We recruited, initially it was conceived of to also include bipolar disorder, but that cohort was never finished. And when I mean that this was a comprehensive characterization, going into the trial, subjects would receive a very large battery of tests, including MEG, sleep studies, polysomnography, 3 Tesla MRI, including DTI and fMRI, 7 Tesla structural MRI, metabolomics, proteomics, ketamine metabolites, and genetics. And some of these results have been published, and some of them are still in the analysis stage. It really created an extremely rich data set. Briefly, the study design, patients with major depressive disorder that came into the clinic on medications were tapered and underwent a 14-day washout, longer if they'd been on fluoxetine. And just to note that all the patients who came to the clinic and were enrolled in the study were currently depressed. So even though they were on medications, they were arguably not effective. So anyone who came in on effectively medicated would not have been enrolled in the trial. After the washout period, subjects were randomized to receive either placebo or ketamine infusions, and the ketamine infusions were 0.5 milligrams per kilogram delivered over 40 minutes, and the placebo was saline. And then after 14 days, subjects would cross over to the opposite infusion. And these blue arrows at the bottom represent the time points of our assessments. So they had imaging assessments at baseline, immediately after the infusion, either the same day in the case of MEG, or a day or two later in the case of the MRI, and then 10 to 11 days post-infusion. And those were carried out for each of the 2 infusions. And here I'm only going to describe data from the baseline and the immediate post-infusion scans. So the behavioral results for the depressed subjects were exactly what we expected. We saw a robust antidepressant effect that was most prominent on the day of the infusion and for several days afterwards, then gradually tapering off. Although in this particular study, there was a significant difference between placebo and ketamine, even up to 11 days after the infusion, but most studies tend to find that the results wear off somewhere between 7 and 14 days. What was somewhat surprising about this study, since it included healthy controls that were characterized using a lot of the same scales as we normally study depression with, was that in our healthy subjects, we saw a robust and rapid increase in depressive symptoms that was present through the next day, actually after the infusion. And while this was somewhat unexpected, when we later went back and reviewed the literature on using ketamine as a probe for things like schizophrenia in healthy populations, we found that indeed there were people with depression also, or people who were healthy also did experience some depressive symptoms that were captured by negative symptom scales for schizophrenia. So this result is not entirely unprecedented. And what we think is that this reflects an overall homeostatic sort of hypothesis for depression, and ketamine being a disruptor of homeostasis. So if healthy controls are in a relative state of homeostasis, then ketamine could kick them out of that, resulting in a depressive response. And the imaging technique I'm going to talk about today is magnetoencephalography, or MEG. And MEG uses some sensitive magnetic field detectors called squids to detect the magnetic fields outside the brain or outside the head that are generated by the brain. It has pretty much equivalent temporal resolution to EEG, very high resolution. But while for EEG, the electric potentials that are measured by the EEG electrodes are conducted by the scalp, and so the signal is somewhat blurred or smeared, and it's difficult to tell exactly where it's coming from. However, with MEG, the magnetic fields actually pass out of the brain and skull unimpeded, and so we can use source reconstruction techniques to predict where the signals originated. And so we can kind of a moderate spatial resolution of MEG on the order of several millimeters. So the emotion evaluation task that was used in this paper, here's a basic layout of it. So the participants were shown a series of emotional faces. They saw each face for about 750 milliseconds, and then there was a two and a half second response window. There were two conditions, an implicit condition and an explicit condition. So in the explicit condition, they were asked to respond according to the emotional expression on the face. And they had two choices. If the face was either sad or angry, they would respond that it was a negative face. And then if the face was either happy or neutral, they would respond that it was a positive neutral face. And then in the implicit condition, they saw the same exact faces with the same expressions, but they were asked to rate the gender instead of the emotion. So that in that way, the emotion would be implicitly processed by the brain. And so the kind of responses we see to face stimuli like this in electrophysiological studies, and this graph is from an EEG study, is that typically if the stimulus is at time zero, about 100 milliseconds post-stimulus, there'll be an evoked field that is corresponding to the early visual component. And then a little bit later, somewhere usually between 140 to 170 milliseconds, there's a face selective response. And so this is just an example of that, a study where people saw objects and faces, and this 170 peak is definitely very specific to face stimuli. Okay. So there were 31 individuals with MDD and 24 healthy volunteers that participated in this portion of the trial, although there were some missing time points for some subjects. The MEG scans were required at baseline and then between 6 and 9 hours post both the ketamine and placebo infusions. And so we formed grand averages of those evoked responses, like the EEG one I showed you on the last screen, to identify temporal windows for peak activity. And we looked at specific anatomically defined ROIs, including primary visual cortex and the calcarine sulcus, bilateral middle occipital cortex, those are higher visual areas, and then bilateral fusiform cortex. One limitation with the trial was that to get enough data points for sufficient averaging and sufficient signal to noise for this study, we ended up combining the implicit and explicit conditions and then only looking at the extremely early response to the faces that would be less likely to be affected by the cognitive components of the task. So we are just capturing the very quick visual and neural face responses. So for each subject, condition, and session time point, we calculated the peak amplitude of the response and then the latency of the response. And we analyzed all these data using linear mixed models in SAS. And then the behavioral task itself, we looked at also using linear mixed models in SAS to look at both reaction time to the stimuli as well as accuracy of the judgments. So first, I'll present some of the baseline behavioral results from the study. So we found significant diagnosis by valence by task interactions. So our participants with major depressive disorder were both faster and more accurate when they were identifying negative faces in the explicit condition as compared to the healthy participants. And it was the opposite situation for the healthy volunteers. They were much less accurate in identifying the negative faces as compared to the healthy volunteers, and were slightly, although they trended towards, although were not significantly, faster and more accurate with identifying the positive faces. And then when we look at the infusion study, so for our infusion results, I'm actually only going to simplify the discussion a little bit. And since we were focused on ketamine as part of this discussion, I'm only going to show the results that differed on the basis of the infusion day, that is to say placebo versus ketamine. So behaviorally, there was a diagnosis by session interaction, where ketamine decreased reaction times and increased accuracy in our healthy participants, but increased reaction time and decreased accuracy in our MDD participants. And then looking at the MEG results at the baseline time point, only the findings for orientation reached our significance threshold for after correcting for multiple comparisons. However, there were some notable findings that did not meet our significance threshold. So in the calcarine sulcus and the left fusiform cortex, our depressed patients did show longer latencies to positive compared to negative faces. And in the right middle occipital cortex, our depressed participants showed larger responses, greater peak activity to negative versus positive faces, with the opposite relationship seen in healthy volunteers. So this really supports a bias towards negative stimuli in major depressive disorder that's been shown multiple times in the literature. It's somewhat controversial in that not all studies uniformly can detect a bias towards negative stimuli, but the preponderance of the literature seems to indicate that's the case, at least in most populations and in most trials. So now looking at the results from the MEG portion of the study, and again, we're only showing those results that included an effect of the drug session, ketamine versus placebo. So in this primary visual area and looking at the very early 100 millisecond evoked field response that is characteristic of processing any visual stimuli, our depressed patient participants exhibited significantly larger responses to emotional faces as compared to healthy volunteers after placebo. However, after ketamine, the healthy volunteers actually saw a significant increase in their responses to these emotional faces. And so while the depressed patients tended to show a reduction in their responses to the emotional faces. So while our depressed participants showed some normalization of their response, they started to look more like the healthy volunteers. Our healthy participants post-ketamine looked much more like our patients with major depressive disorder under placebo. And notably, this finding was generalized to all the emotional faces and not specific to a positive or negative valence. So in the left fusiform, and this peak would correspond to the later M170 face response, we again found that ketamine increased responses to emotional stimuli, but in this case, it did it in both patients and in subjects with depression. So this was a more uniform effect. And then finally, in the right fusiform gyrus, similar to the calcarine sulcus, there was a significant diagnosis by session interaction. None of the post hoc tests were independently significant. However, the trend, again, was that post-ketamine, the healthy volunteers showed an increase in their responses, in the amplitude of their response to emotional phases, whereas the depressed patients who showed elevated responses under placebo compared to the healthy controls showed a reduction in their responsivity to the emotional phases. So summarizing these MEG findings, we found that most of the effects of ketamine were differential between MDD and healthy volunteer participants, although there was one finding that was generalized across all subjects. Notably, the effects that we observed of ketamine were not valence specific. They were general to emotional phases in general. And the effect of ketamine seemed to be to increase reactivity to emotional stimuli in healthy participants and to decrease reactivity to emotional stimuli in our depressed participants. And so the final analysis that we did in this paper was to incorporate the antidepressant effect. And so we measured depressive symptoms using the Montgomery-Åsberg Depression Rating Scale, or MADRS. And this was done at multiple time points. We include here, we calculate the percent change in MADRS from pre-infusion to 1 day post-infusion, as that is the most common time point used in the literature to measure the antidepressant response to ketamine. And so in the areas where we saw significant effects of ketamine, repeated those analyses, but this time using the percent change in MADRS score post-ketamine as a covariate. And the graphs here, MADRS is parameterized so that a negative value represents improvement, and these were mean-centered, so they're a bit off-center there. We didn't see as much improvement as you would expect looking at these graphs, but that was because we mean-centered the covariate. And so in this case, when we included the antidepressant response, what we found is that valence specificity did emerge in the response to ketamine. And of course, this is only in the depressed subjects, though we didn't have, it's a little bit more complicated to combine the healthy controls percent change in MADRS to day one, because most of them started from a MADRS of 0 or 1. But regardless, what we saw was that if post-ketamine participants saw a heightened response to negative stimuli and a blunted response to positive stimuli, they tended to have a poor antidepressant effect. So again, what's notable about this is the valence specificity in ketamine's effects did emerge once we included the antidepressant response. And so additionally, in the right fusiform, we also showed an association with the antidepressant effect. It was not valence specific this time, but it followed kind of the same pattern that we're used to seeing, in that a heightened response to emotional stimuli in general was associated with a poorer antidepressant response. So just to sum up the results that I've presented as part of this paper, in the behavioral results, we did observe a negative processing bias in our depressed participants that was apparent at baseline, and this was found in the behavioral results, but it was not significant in our MEG results. Behaviorally, ketamine's behavioral effects weren't valence specific. However, ketamine appeared to make the MDD participants look more like healthy volunteers under placebo, and vice versa. And in the MEG results, we found that ketamine can produce differential effects between depressed and healthy volunteer participants. And these effects were not valence specific, but showed that ketamine generally increased emotional reactivity in healthy volunteer patients while decreasing it in depressed patients. Valence-specific effects of ketamine were only evident when taking MADRS response into consideration, and larger responses to negative phases and lower responses to positive phases were associated with poor antidepressant response. So what do we think this means? And again, to go back to this homeostasis hypothesis that I introduced at the beginning, homeostasis in the brain can be thought of as a balance between inhibition and excitation. And of course, there's a very, very narrow window in which this balance occurs. And any deviation from homeostasis via too much inhibition or too much excitation may lead to psychopathology. And ketamine, as we know, because it is because it does affect the glutamatergic system, can directly affect the excitation inhibition balance. And so the way we conceive of homeostasis in depression is that healthy controls may be at a relative point of homeostasis, whereas depressed participants may be subtly off a homeostatic set point. Whereas an infusion of ketamine, while that may take a depressed patient to a point of homeostasis for a short period of time, for a healthy participant to receive an infusion of ketamine may disrupt the homeostatic balance in that participant, resulting in transient depressive symptoms. Sorry, my animation did not work there. And just to briefly acknowledge everyone who participated in this study, the work was actually carried out in the lab of Carlos Zarate, who runs the mood disorders behavioral health program at the NIH. Nancy Lundin and Linnea Sepe-Forrest were two trainees working with me that did the bulk of the data analysis, and we had additional scientific support as well, as in addition to all the nursing and clinical staff. And of course, we're very indebted to the patients and their families. Thank you.
Thank you very much. It's been like very interesting research, very interesting overview. I may start with a couple of questions, and then I saw already some of them are in the Q&A. Please feel free to just like keep writing them there. That would be helpful. So I was wondering, Allison, like it was my understanding, like you did the MEG after the infusion, right?
Yes.
Few hours after, and then you look at the antidepressant response at 24 hours. Do you think that these can inform us in a way, in a sort of like early predictor of ketamine response? At 24 hours?
That's definitely a hope. And in fact, we're actually there's a study going on right now where they're actually giving infusions during an MEG recording period. It's been a slow study to recruit for, of course, with even before COVID, it's a difficult study to carry out. But we're hoping that looking at the gamma power response to ketamine, which we know occurs, if there may be aspects of that we can use to predict the responsivity to ketamine. And yes, I do think that studies such as these could potentially contribute to finding out who will be a responder or not. But ideally, we want to find markers that we can give to them before we give them the drug, rather than.
Yeah, no, and that was like my follow-up question. Do we have any evidence that a baseline may predict this antidepressant response?
There have been numerous findings of baseline predictors to ketamine, as well as to many other antidepressants. Most, unfortunately, have not yet been validated. They've been found in a single study, but they haven't yet undergone multiple repeated trials that would allow us to really be able to say whether or not that's a biomarker yet. So I think there are some candidates in the literature, several including connectivity, global brain connectivity, responsivity to emotional tasks like this one. But up to this point, there's not yet one predictor that I think we can reliably say will predict response. But I'm conservative on that.
And I think just have a couple of more questions before leading to the audience. One of those was like, I think you said, and it was probably mostly due for a statistical power. I think you mentioned that you collapsed together the happy and the neutral phases. And I was wondering if these may have had some influence on the results, or, sometimes there is the neutral phases might be perceived as a bit ambiguous for depressed patients. So I was wondering if you can comment on that.
Absolutely. And I think this was one of the cases where kind of hindsight was 2020. And when we started to look at the behavioral data and look at, accuracy values between patients and controls on these responses, we began to wonder if that part of the issue was how people were responding to negative, or how people were responding to the neutral phases. And I think our depressed cohort would be more likely to respond to those neutral phases as if they were negative, whereas our healthy cohort may be more likely to respond to them as though they were positive. So I think, if we were to repeat this trial today, we would definitely structure our tasks so that we could parse those out, because the neutral phases are ambiguous. It's very true, and it most certainly could have affected our findings.
We have a question here from Dr. Harmer. Let me read this for you. Do your results suggest some emotional blunting in MDD across participants, which is most useful when it affects negative affect bias in relation to depression change?
Yes, I would say that that's pretty much exactly what we observed in the depressed subjects. They showed this enhanced reactivity to the emotional phases at baseline or under placebo infusion, and then under ketamine infusion that was blunted. And then, of course, interestingly, the healthy volunteers showed this enhanced emotional reactivity. And yes, it did appear at least in the one fusiform brain region, that it was most important when it occurred to the negative affect phases. And I think these kind of changes that we see in reactivity to stimuli have been shown in other more basic sensory tasks as well. For example, we also did a somatosensory task, both as part of this study as well as part of an earlier ketamine trial, where we saw kind of enhanced neuronal excitability that was related to the antidepressant effect as well.